Hi, hello everyone. Welcome to our webinar. This is your host, Dr. Ammar, and I just want to check if everyone can see me and hear me. Good morning, everyone, or good afternoon, depending on where you are. And so today we're going to be going over the high-yield MI and ischemic heart disease in general for the STEP exams. This will be beneficial for both Step 1 and Step 2, so it doesn't really matter if you're doing either. And before we jump in and I give you some background about the structure of this webinar, I'm going to introduce myself. My name is Dr. Ammar, and I am an IMG doctor. I've been tutoring for 6 years now. I've passed Step 1 and scored 270 on the Step 2 CK exam. And today, I'm going to be talking about the ischemic heart diseases, which are a group of disorders. Most notable one of them and the most high yield is going to be MI. Now, this webinar is structured in a way where we're going first to address the pathophysiology of these ischemic heart diseases, so how they happen. And then we're going to talk about the diagnosis. So how do we diagnose them? How do we localize the problem to which coronary artery? What are the presenting symptoms and how to interpret the ECGs? And then we're going to talk about some really important differences in different types of MIs. And we're going to be talking about differential diagnoses. So other diseases that can manifest with chest pain, which is the most important symptom in ischemic heart disease. And then we're going to discuss the management of ischemic heart disease and MIs, the prevention, and the last thing is going to be the complications, the high-yield complications that you should expect with STEMIs or with MIs. And then towards the end, we're going to go over two long-form questions, very similar to how the exam questions are going to be, and we're going to try to apply what we learned today. So without further ado, let's get into this. So ischemic heart diseases. Ischemic heart diseases are a group of disorders that range in severity, but all of them have very similar pathophysiology behind them. So the pathophysiology, the main driver of all ischemic heart diseases is going to be atherosclerosis. And atherosclerosis, in a nutshell, it's poorly understood, but we know that there are a bunch of risk factors for atherosclerosis, including high lipids in the blood, most notably the LDL. It is associated with obesity, can also be associated with hypertension and some genetic factors. So it's a multifactorial process. But what we care about is what exactly happens in the setting of atherosclerosis. We're going to have the deposition. So here is a depiction of an artery. Let's suppose that this is a coronary artery, one of the arteries that supply the muscle of the heart. And we're going to have some buildup of lipids on the walls of these blood vessels. And this is what we call the atherosclerotic plaque. And this is the driving issue of everything else that we're going to discuss today. So let's first discuss what are the different types of ischemic heart disease. And we classify them based on severity. So from the less severe, which is the stable angina, and then we're going to have what we call unstable angina or unSTEMI. And then the most severe one is going to be STEMI. Let's discuss the pathophysiology of each, okay, and the main symptoms. In today's session, I'll focus more on the STEMI because these are the most important tested concept about ischemic heart diseases. So stable angina just basically means that we have this plaque obstructing blood flow to the heart muscle. And generally, when we start having these depositions of lipids on the walls of the blood vessels, you're going to have some limitation of blood flow to the heart muscle. But this will be fine and compensated for because the heart is going to respond by dilating these arteries so we can get more blood flow until it hits a critical stage. And this critical stage, it varies, but most sources agree on around 70% or more. So if the lumen or the diameter of the blood vessel, the coronary blood vessel, is obstructed by more than 70%, then these patients are going to start showing the symptoms of stable angina. What are the symptoms of stable angina? The most important one is going to be chest pain with exertion. So chest pain, and it's going to be with exertion, not at rest. Why? Because if you ever have chest pain at rest, then we're talking about the other disorders. We're talking about an NSTEMI or a STEMI. And now let's discuss the pathophysiology of, I have grouped unstable angina and STEMI in one group because they are very, very similar. And now clinically, we do not distinguish between them. We treat them as the same disease because, I mean, in effect, they are, and they have the same treatment and same pathophysiology and everything. So in NSTEMI, what is going to happen is now that this plaque that we talked about, it is going under stress, heightened stress, it is going to rupture. And once it ruptures, it's going to release some material into the blood vessel, like collagen, like some lipids. And the bad thing about these substances that the plaque rupture is going to release is that these substances are really highly thrombogenic. So they're going to precipitate the formation of a thrombus or a clot, the clot that is going to be made up of platelets and then fibrin. So here we're going to have a clot overlying the rupture of the atherosclerotic plaque. And this will, as you guys can see, can even further limit the blood flow into the muscle. And what characterizes unstable angina or NSTEMI is that we're not going to have a total occlusion. So we still have here like a small place where blood can flow. Yes, the blood is going to be severely limited, but we still can have some flow. And in these patients, we're not going to have full infarction, or meaning a transmural infarction, an infarction or death of the muscle that involves the whole thickness of the wall of the heart. It is going to be what we call a subendocardial or a partial infarction. And this one is going to be presenting with chest pain as well. And then STEMI, which is the last one and the most severe one, it is going to be when the thrombus that formed is going to completely 100% obstruct blood flow. So now we're going to have limited blood flow to the heart muscle. The heart muscle is going to start to die. And this is the basic pathophysiology of all of these diseases. And the one important concept about these diseases and their management is that now you're going to have a mismatch between the supply of oxygen and nutrients to the heart muscle and the demand of the heart muscle for oxygen and nutrients, because you're going to have severely decreased supply. In all cases, you're going to have decreased supply because you have less blood flow to the area. In STEMI, it's going to be a complete cutoff of supply. In stable angina, it's also going to be a huge limitation in this supply. And the demand can stay the same or can increase. But now we're going to have a huge mismatch between the supply of oxygen and blood to the heart and the demand of the heart. And this is super important. We're going to go back to it again because the treatments or the managements of these disorders depend on the supply and the demand. We are going to restore the balance. Mainly, we can do that either in two ways. So since we have a problem with decreasing the supply, the main treatment for ischemic heart disease and STEMI is going to be to restore this supply. How do we restore this supply? Through PCI, or a percutaneous intervention, where we're going to go through a catheter inside of this blocked artery and then pop up a balloon to open up the artery and restore blood flow. Most of the medical management is going to be involving the demand of the heart. So we're going to try to lower the demand as much as we can. So now the heart does not need much oxygen and much nutrients, so it can do with what it gets. And the demand mainly depends on four things. The demand of the heart, which are the targets of all of the drugs. We're going to come back to this when we talk about the drugs and see how they affect the demand. So the demand depends on, one, the preload of the heart. Two, depends on the afterload of the heart. Three, depends on the heart rate. And number four, depends on the contractility. So I'm going to briefly explain what each of these mean. So preload just basically means how much blood is coming back to the heart, or how much blood does the heart need to be pumping. The more preload, it means that the more demand. Now the heart has to work harder because it needs to pump more blood. So we need to be lowering this preload in the management. The afterload is basically the resistance that the heart has to overcome to pump the blood. And it is merely determined by the blood vessels. How narrowed or dilated are they? So the blood pressure, in effect. So, and we try to lower the afterload. Number 3 is the heart rate. That's self-explanatory. More heart rate, the heart has to pump more and pump faster, and it means now it's going to need more oxygen, so the demand is going to be higher. We try to lower the heart rate. And contractility, which is the force of contraction of the heart. How hard can the heart contract? And the higher the contractility, it means that the higher the demand is, and we need to be lowering that in the management of ischemic heart diseases. So now let's talk about STEMIs. We're going to discuss the main differences between STEMIs and non-STEMIs in a bit, but the main one, it's in the name. STEMI includes ST elevation, and non-STEMI does not include ST elevation. And ST elevation is something that we're going to see on the ECG. So first of all, how would you approach, or how would you know that a question is asking about MI? Well, what are the symptoms? The main symptom and the most common one is going to be chest pain. So I'm going to tell you all of the symptoms. So chest pain is found in like more than 90% of cases. Now, there are some other symptoms that are found, like, for example, dyspnea, also found in a lot of patients, more than 80%. Dyspnea just means breathlessness or inability to breathe or difficulty in breathing. Then you have some other symptoms that sometimes can show up in tricky questions. It would be someone with MI, but they do not have the chest pain. So you do not effectively rule out MI if you do not have chest pain. Other things include nausea. So nausea can be found in 50% of patients, or 50% of cases. Sometimes a very rare presentation of MI, but it shows up on the exam, is epigastric pain. Sometimes the pain is not in the chest. Sometimes it is, especially in older patients, it is felt in the epigastrium, or where the stomach is. And this is found in approximately 20% of patients. So it is a rare presenting symptom. So these are the presenting symptoms. So someone comes to the AD with these symptoms, you should be thinking about MI first, and you should order an ECG as soon as the patient comes in. Now, the changes in the ECG are going to allow us to know what part or what wall of the heart is involved or is dying. And there are 3 important localizations that you should know. You should know what kind of leads are involved, what is the vessel that is most likely going to be occluded, and what is the location, which is what part of the heart is involved. And first, I'm going to talk about the most important one, which is the anterior MI. It is the most common one. And the anterior MI mostly involves blockage of the left anterior descending, or the LAD artery. Now, the coronary arteries, we have 2 coronary arteries main. So we have one, which is the left. This is the left. And we have another one here, which is the right. And the left is going to branch into 2 branches, 2 main branches. This one is we're going to call it the circumflex, the left circumflex, which is mostly going to wrap around the heart and supply the lateral wall of the heart, this part of the heart. And then we're going to have the left anterior descending, which is going to be supplying most of the anterior portion of the heart. And then we have also the right coronary artery, which is going to be supplying most of the back of the heart and the inferior wall of the heart, so this part of the heart. So going back to the localizations, we said that an anterior MI, sometimes we also call it a septal. This is mostly implicated in a LAD occlusion, and the leads that we're going to see the ST elevation in are going to be leads like V1, so the chest leads V1, V2, V3, and V4, and we're going to be looking at ECGs next to identify this. The second important location is going to be in the lateral wall of the heart. And the lateral wall of the heart is mainly supplied by a branch of the left main coronary artery, which is the left circumflex artery. So if we have ST elevations in the lateral leads, this means that the most likely vessel to be occluded is the left circumflex, and the leads are going to be lead 1, lead AVL, and V5 and V6. And then the last important location, which is also we're going to be discussing about unique features about this type of infarction, is an inferior AMI involving the inferior wall of the heart. This is mostly going to be an obstruction in the right coronary artery in most people, around 90% of cases. Now we have like a some minority of people where it is going to be the left circumflex, but this is like the exception, not the rule. The rule is going to be the right coronary artery. And the leads that we're going to see the ST elevation in are going to be leads 2, leads 3, and lead EVF. Now, these are two ECGs. Can we look at them together and try to identify which part of the heart is involved? So what type of infarction is this? What is the location? And what is the obstructed artery? Because they're going to ask you questions like these on the exam. So let's look at this one first. So here I'm mostly saying ST elevations. So ST is the segment between the QRS and the T wave. And it should be isoelectric, meaning it should be flat. If it is elevated, that's an ST elevation for you. And here I can see ST elevation in lead V2. This should be the ST segment. It should be flat, but here we can see it elevated. So that's an ST elevation. Same in V3. And we can also see it in V4 and slightly in V5. So this is mostly going to be an anterior AMI. And the vessel that is occluded is going to be the left anterior descending vessel. So this is what a normal ST segment, if we look at lead 2, we can also look at it here. This is what a normal ST segment should look like. It should not look elevated. But you can see in V2, V3, V4, V5, we can see the elevation in the ST segment. This is another ECG. And can you guys type in the chat what you think this is? What type of infarction or what type of leads can you see the ST elevation in? Yes, it is inferior, yes. And okay, and I can see lead 2, so we can see the ST elevation here. We can see it in lead 3 as well, and we can see it in lead AVF. Now in V2 and V3, we have these other changes in the ST segment, but these are not ST elevations. They're depressions and the reciprocal changes. You don't have to worry about them that much. Just worry about identifying where is the ST elevation. So this is an inferior AMI, and the most commonly implicated artery is going to be a right coronary artery. Okay, so now let's discuss about the different types of AMI, or sorry, different types of ischemic heart disease. So stable angina, I'm not going to discuss much about it. It just relates to decreased blood flow to the heart. And it presents mainly with chest pain with exertion. Now, these three, we group them together, and we call them the acute coronary syndrome because they mainly present with the same pathophysiology, which is going to be, as we explained, a rupture, a block rupture, in addition to a superimposed thrombus that's going to develop overlying this rupture that's going to cause an occlusion. An unstable angina and STEMI is going to be a subtotal occlusion, so not the whole thing, maybe 90% or a little bit more. In STEMI, it's going to be a total occlusion, and you're going to see the ST elevations. The type of ECG manifestations that you're going to see in unSTEMI are going to be other ECG changes that are not ST elevation, like ST depressions or T wave inversions. And the treatment is different between both. So both of them, the most important treatment, as we said, in any kind of an acute coronary syndrome would involve revascularization, which is PCI, meaning that we go in, we open up the balloon, we restore the blood flow. But in a STEMI, this is going to be emergent, and we like to do the PCI within 90 minutes. from presentation to the hospital. So like a patient comes in at, let's say, 6 p.m. and then by 7:30 p.m., the balloon should be open and we should have restored the blood flow. That's the optimal way to do it. In unstemy or unstable angina, you still do revascularization, but it is not emergent. You're mainly going to do it within 24 to 48 hours. So it is not a race like with STEMI. We're going to discuss the medical treatment of both when we talk about the management part. So now I want to focus about really unique differences between anterolateral AMIs, which is AMIs that involve either the anterior wall or the lateral wall. Mostly they are going to involve the left ventricle, and in infarction involving the inferior wall, which can involve parts of the right ventricle. So the anterolateral AMIs, what are the symptoms? So we have the shared symptoms of chest pain, and chest pain is caused by the dying muscle. So if we have a STEMI that involves heart muscle dying, you're going to have the chest pain. But I want to focus about important symptoms. So in anterolateral AMI, you can have pulmonary edema, where you're going to have fluid back up into the lung, and fluid in the lung, which causes dyspnea, difficulty breathing, can cause crackles that we hear on the chest examination. While in an inferior AMI, you're going to have clear lungs. So the lungs, you're not going to have fluids in the lungs, but what you might have is a jugular venous distension. I'm going to explain the exact hemodynamics of these differences. ECG, I think we already discussed the ECGs of anterolateral inferior. Inferior is going to be in 2, 3, and AVF, while anterolateral is mostly going to involve the chest leads. The chest leads are leads V1 through V6. These are the chest leads. Now, what about the hemodynamics, or what are the changes that we're going to have in the hemodynamics? I'm going to put a drawing here and let's try to imagine what's going on. So this is a drawing for the left, the anterolateral AMI, and this is a drawing for the inferior AMI. So this is a rough diagram of the heart. I know that the heart is not square, but to make things easier. So this should be the left ventricle, left atrium, right atrium, and then right ventricle. So what is the main problem in an anterolateral AMI? The main problem is that the left ventricle is weak. Muscle has died, and now the left ventricle cannot effectively pump fluid forward or pump blood forward because it has suffered an infarction. Muscle are dying, so the heart is weaker. So what is going to happen now, instead of the normal course, which is the left ventricle should be pumping fluid through the aorta. So this is the aorta, which is the artery that is attached to the left ventricle. We're going to have less fluid moving through the aorta, and because now the left ventricle cannot really pump effectively. And when blood cannot move forward, blood will accumulate, and blood will start backing up forward. So the hemodynamics, we're going to see an increase in the left ventricular preload, meaning the left ventricular preload, how much blood there is in the left ventricle, and there's going to be some blood that is accumulating in the left ventricle because the left ventricle is weaker. Now, some of this blood is going to start to backflow. Since it cannot move forward, it's going to backflow from the left ventricle to the left atrium because they're connected. And then from the left atrium, also blood is going to backflow. Now, what is the vessel that is connected to the left atrium? It is the pulmonary vein. So this is the pulmonary vein. Blood is going to back up through the pulmonary vein into where? Into the lungs. So these are the lungs. And now you're going to have more blood in the lungs. And this blood in the lungs can then be filtered through the vessels and leak from the vessels and accumulate in the lungs, that are going to have edema or fluid over the lungs. And that's why we're going to have a pulmonary edema in the anterolateral AMIs, and an increase in left ventricular preload. Now also the lungs, the blood in the lungs is going to also back up. So where is it going to backflow? The lungs are connected to the right ventricle. So the vessel that's connected to the right ventricle is the pulmonary artery. And now all of this blood is also going to backflow to the pulmonary artery, to the right ventricle, and now you're going to have more blood in the right ventricle as well. And this should increase the right ventricular preload. So you're going to have an increase in both the left ventricular preload and the right ventricular preload in an anterolateral MI. Now let's discuss what is going to happen in an inferior MI that is mostly going to involve the right ventricle. So this is another drawing of the heart. Left ventricle, left atrium, right ventricle, right atrium. Now, since the problem is going to be in the right ventricle, where the right ventricle is weak, now because the muscle has died, it cannot effectively pump fluid or blood forward. We know that the vessel that is connected to the right ventricle should be the pulmonary artery, and the pulmonary artery should be sending the blood through the lungs and then back to the heart. Now, since the right ventricle is weak, blood is going to start to move to back up. Okay, so from the right ventricle is going to back up into the right atrium. What are the vessels that are connected to the right atrium? The central veins of the body, which are going to be the superior vena cava and the inferior vena cava. So these are the superior vena cava, and you're going to have the inferior vena cava as well here. And blood is going to back up through, let's discuss the superior vena cava. And the superior vena cava is directly draining the veins in the neck and the veins in the head as well. And this will show up clinically as what we call a jugular venous distension, because blood is going to back up into the jugular veins, into the neck, and the jugular veins are going to have so much blood, they're going to be congested and dilated, and this will be a jugular venous distension. And that's why we are going to have a jugular venous distension in inferior MI. And now, coming back to the right ventricle, since the right ventricle, we said, cannot effectively pump fluid or blood forward, but the blood that we're pumping from the right ventricle should flow through the pulmonary artery and then go back where? It should go back to the left atrium. And then here we should have the lungs. And then it should come back to the left atrium through the pulmonary veins. Now, since we have less fluid or less blood being pumped by the right ventricle, so we're going to have less blood coming back to the left heart and the left atrium, and also less fluid in the left ventricle, and less blood in the left ventricle. And this is why we're going to have a decrease in the left ventricular preload in an infarction involving the right ventricle, and we're going to have an increase in the right ventricular preload because we know that blood is going to accumulate in the right ventricle and start backflowing. So these are the important hemodynamics between anterolateral and inferior. These are super important in the management, okay? So one of the most important things that we do as part of the management of a STEMI is we give drugs like nitrates, and we might give diuretics as well. They're not standard, but we might give them. But why we do that? So why do we give nitrates and diuretics? Okay, coming back to the diagram here about the demand. In MIs, we need to be decreasing the demand on the heart, and we can do that through multiple things. So nitrates are going to be decreasing the preload. Why? Because nitrates are venodilators. See that they dilate the veins, and now more blood stays in the veins and does not come back to the heart. So, and we do that to decrease the demand of the heart and now decrease how much the heart has to work. And this works wonderful for the anterolateral STEMI, which is the most common type of STEMI. And diuretics, kind of the same thing. Diuretics, you just diurese the body, get rid of the fluids, and this should decrease the preload. Now, what you should be aware of is that these are super contraindicated in an infarction involving the inferior wall of the heart. So you cannot do that because these patients are already struggling to pump through the right ventricle. And these are patients that we call preload dependent. So they're just like whatever kind of blood that they can pump through the pulmonary artery are going to pump through the lungs and then come back to the heart. And then we're going to pump that through the left ventricle. But we have a decrease in the left ventricular preload. If you give them something that further decreases the preload, this will risk severe hypotension or a decrease in the blood pressure. because I mean, these people are already having very low blood coming back to the left ventricle. Imagine if you just decrease that even more. That would be a contraindication, and that's why never give nitrates, because nitrates, or like nitroglycerin, are one of the first things that could be done in an MI. If you identify these ST elevations in these leads 2, 3, and AVF, don't give nitrates. That's contraindicated. Instead, what you can give is you can give them fluids. You can give them IV fluids to help the right ventricle push more blood back to the left ventricle and maintain the blood pressure as much as we can. So these are important differences between anterolateral versus inferior. We're going to be discussing some other things, like, for example, in the inferior, it is unique because it can present with low heart rate or bradycardia. That is something very unique about the inferior MIs. Why? Because the right coronary artery, which is implicated in an inferior MI, is going to be supplying this part of the heart and this part of the heart, which are the SA node and the AV node. And if there is any ischemia hitting these nodes, then the heart is not going to be able to generate enough impulses or to keep the heart rate increased. So the heart rate is going to go down, and this is what we call bradycardia, which is one of the important manifestations that we can uniquely see in an inferior MI. Now let's discuss some other differential diagnoses so they don't trick you on the exam of chest pain. And the three most important ones, in my opinion, include aortic dissection. Now, how to differentiate aortic dissection from MI? First of all, the character of the pain. So the type of pain that we're going to have in an MI is mostly going to be the crushing type of pain, heavy pain, maybe can be described as a pressure-like pain. Aortic dissection, the character of the pain mostly is going to be really severe tearing pain. And it also characteristically can radiate into the back. So they can present either with a chest pain or a back pain. These people mostly are going to present with high blood pressure. They're going to be hypertensive because that is the most common or most important risk factor for an aortic dissection. And they might have some blood pressure differences between both arms. And this is something as well, very important aortic dissection. On a chest x-ray, you can also use a chest x-ray to differentiate, because an aortic dissection, you're going to have what we call a widened mediastinum. What is a mediastinum? It is the area in the middle of the chest where you have the heart and you have the great vessels that leave the heart, like the aorta. And because aortic dissection will cause enlargement of the aorta, so you're going to see a widened mediastinum on a chest x-ray. Now, what about PE? So PE is an embolism or a clot that will clog the lungs and prevent the blood from flowing freely through the lungs. I would say the most important thing to differentiate between MI and a PE would also first be about the character of the pain. So in PE, the pain are what we describe as a pleuritic pain or pleuritic chest pain, which is pain that is going to be described as sharp pain, and also the intensity of the pain is going to increase with inspiration. So when they're trying to take breaths, they're going to feel the pain, and that's why they take shallow breaths. They don't take deep breaths. And I believe that the most important way that you can differentiate is in PE, mostly you're going to be given some clues that point you to a hypercoagulability problem, which are things that you can review called the modified Wells criteria, which is a type of a decision-making tool that we use. We have different criteria and we give points depending on these criteria. And if you have enough points, then it means that you have enough suspicion of PE. These points relate to the hypercoagulability. Does this patient have an increased risk of forming clots and then sending them to the lungs? They include things like cancer. They include things like maybe they had a clot in their leg, a DVT, which is a very strong indicator. Most of the cases of PE originate from the legs, and then they travel to the lungs and block the lungs. It would be maybe recent surgery. So these type of things or type of risk factors are going to be present in the question. And acute pericarditis is also going to be a pleuritic chest pain. And acute pericarditis usually is positional, meaning that the intensity of the pain will change with the position. Usually the pain is exacerbated lying down, and it is going to be relieved when you sit up. And also there's going to be no relief with nitroglycerin, no relief with nitro. Usually nitro is very important for MI, helps relieve MI really fast because it's going to decrease the demand of the heart. There's going to be no relief with nitro. Sometimes you can see plus or minus a fever. And the changes in the ECG are also super important for acute pericarditis. The changes characterized with acute pericarditis are going to be diffuse ST segment elevation. ST elevation. So ST elevation in all leads, not just one or two or three like what we see with STEMI. So it's going to be diffuse ST elevation with sometimes we also see PR depression, which is the PR segment being lower than usual. So these are also clues that we can use to help us differentiate the causes of chest pain that we're having. So now let's discuss about the management of a STEMI. And now the most important thing that you should do in a STEMI again is going to be the PCI as soon as possible and within 19 minutes. But while we're waiting for the PCI and for the cath lab to be activated and all of that, there are some medical managements that we can do, and all of them relate to the demand. So nitrates, we said that they are going to work through causing venodilation. So dilating the veins, and this will mean more blood is going to pool in the veins and less blood is going to come back to the heart. So you're going to be decreasing the preload. Beta blockers are also important. Beta blockers, they block the beta receptors in the heart, and this will cause a decrease in the heart rate and also a decrease in the contractility. And when you decrease both, you're going to decrease the work of the heart. The heart is not going to be working as hard anymore. Antiplatelets and anticoagulation are also important parts of the management because STEMI is not just an ischemic disease, meaning that there's only ischemia or decreased blood flow. That's what ischemia means. It's also a thrombotic disease, meaning that there's a thrombus or a big clot that formed. And that's why we use these medications. Antiplatelets, we like to use what we call dual antiplatelet therapy with two drugs, which are the most common ones are going to be clopidogrel. And clopidogrel works through inactivating the ADP receptor. It's an ADP receptor blocker. And add to that, aspirin is very commonly used. It's also another antiplatelet medication. Now, aspirin is going to be continued indefinitely. Okay, so forever. If you had one episode of AMI, you're probably gonna be in aspirin for the rest of your life. Clopidogrel, we do it only for 12 months. And then we stop. Anticoagulation is done in the hospital also because you want to prevent this thrombus from maybe getting bigger or moving somewhere else. And the main drug that we use is usually heparin. You can use other anticoagulant medications like enoxaparin, but heparin is the main one. And also statins. Statins, they help us in stabilizing this plaque. So because we said that the main driver was the plaque and then it ruptured and then we have a thrombus forming. So statins help us in keeping the plaque stable, not rupturing again. And then other supportive measures, you give them oxygen if they have difficulty breathing. You also give them something for the pain like morphine, and other supportive measures while you wait for the main treatment, which is PCI. Now let's talk about the prevention of MI. And the prevention of MI falls into two important categories, which are going to be either primary or secondary prevention. So what is the difference? Primary, it means that you have not had MI before, and we want to decrease your risk of having MI. And secondary, it means you had an episode of MI, and we don't want you to have an episode again. And there are two important ways that we can do that. There's always the lifestyle way, and there's the medical management way. So let's talk about the secondary prevention first, and then we're going to talk about the primary prevention. So the secondary prevention, it means that you had an MI and we don't want you to have an MI in the future. So lifestyle interventions include smoking. And if they ask you a question about what is the most effective single intervention to prevent recurrence of MI, it would be smoking. Smoking, because it hugely increases the risk of MI, and stopping smoking. Other things could be exercise and a diet. Now they're focusing more on nutrition in the on the USMLE. So a diet that is really good for the heart disease include the Mediterranean diet, which is a diet that is rich in full grains and rich in vegetables. And now we have the medical part. By the way, just a note, I'm going to be dedicating the last 10 minutes of the session for you guys if you have any questions that you want to ask. I see someone in the comments mentioning DASH. DASH is very important for blood pressure control. So now let's talk about the medical part of the prevention. So you have to optimize blood pressure. That is super important. And the best way to do that after an MI, and the best drug, most effective drug, is going to be an ACE inhibitor. Okay? Because an ACE inhibitor does not only lower the blood pressure, we need the blood pressure to be less than 130/80. After MI to prevent recurrence of MI. And the best drug to do that is ACE inhibitor because it also has some favorable effects on the heart itself. It prevents remodeling and bad changes that can happen to the heart. And we have to optimize lipids, LDL. And we already talked about statin. You also continue statin after an MI to prevent the recurrence. We have to do something about the platelets as well to prevent any thrombus from forming again. And the way you do that is aspirin indefinitely. And then you have to optimize glucose. If the patient does have diabetes, you optimize glucose. One important drug that you can do that is the SGLT2 inhibitors. So these drugs the flozins are very important, like dapagliflozin are super important because they're also protective for the heart and they help with the diabetes. Now, what about primary prevention? The lifestyle interventions are going to be the same. So smoking, exercise, diet. What about the medical management or the medical prevention, primary prevention? It mainly revolves around LDL, okay? So because we know that lipids have a central role in the development of MI, so we need to lower the lipids as much as we can. And we do that through statins. We give the patient the drug statins, which are drugs that lowers the LDL in the blood. Now, who deserves a statin? Since we said that this is primary prevention, meaning the patient did not have MI, and we want to prophylax them or prevent them from having any MIs in the future. So who is deserving of a statin? First of all, if the LDL levels are more than 190, you start them on statins. This is the first indication. Second indication, if they have diabetes and they're older than 40 years, that they also deserve a statin. So it does not matter what is the LDL level. If they have diabetes, they're older than 40, you start them on a statin. And the third is something that's not really super important. We have a calculator sort of, and you put in a lot of details about the patient's history and the patient's diseases and everything, and it calculates a risk for you. And if this risk was more than 10%, then you also start the patient on LDL. The risk is a risk of this patient having an MI in the future. If the risk is more than 10%, you also start them on statins. And these are the main indications for starting statins in someone that have not had an MI before. So now let's talk about the last part about the MIs, which are the complications. And I like to think about the complications in two ways. I break them down into either electrical complications or mechanical complications, because the heart, there is the mechanical part of the heart, which are mainly the muscles, the valves, and they're responsible for the flow of blood. And then you have the electrical part, the electrical conduction system of the heart that stimulates the heart to contract. And you might have problems in either because of the infarction, the death of the muscle, because you're not only going to have death of the muscle, you might be affecting the conduction system, like the wiring inside of the heart. And the most important electrical complications include ventricular arrhythmias. So arrhythmias in the ventricle, especially if the MI is super big, like a massive MI, and it is involving a big part of the ventricles, then it can predispose to ventricular arrhythmias. Most common are VTAC, which is ventricular tachycardia, or VFib. And actually, ventricular arrhythmias are the most common cause of death in MI. So a patient had MI, then they died. That is, they died like during the MI or on their way to the hospital. Most common cause would be an arrhythmia. most likely it's going to be a ventricular arrhythmia. So most common cause of death in MI is going to be arrhythmias. And then the other manifestation are the bradyarrhythmias. And again, to kind of connect things together, we said that these are much more common in inferior wall MI. And the bradyarrhythmias, they include things like you're going to have bradycardia, if you have involvement maybe of the SA node, and you might have a sort of an AV block or a heart block if you involve the AV node. So a heart block can be either a second degree or a complete third degree AV block. And these are the electrical complications of MI. Now, what about the mechanical complications of MI? Now, they are not super common to happen, but they are commonly tested on the exam, and we have to know all of the mechanical complications. Now, the way that I like to think about the mechanical complications of the heart is to get questions right about them. You have to take the time into consideration. So when did this happen? How soon after an MI? Because the first two complications that we're going to discuss, they happen within a week, usually after 3 to 4 days, but within a week's time of an MI, then the patients are going to come back again with some complication that happened. And one of the most commonly tested ones are the papillary muscle rupture and dysfunction, leading to mitral regurgitation. So let's take a step back and discuss what does this mean. So what are the papillary muscles? The papillary muscles are these muscles, and these muscles, they connect to the valve. This is the mitral valve that separate the left atrium from the left ventricle. And the valve is hooked up to these muscles that help keep the valve closed and working normally. Now, if we have an acute myocardial infarction event like this, we have a thrombus that formed in one of the arteries, and the most common artery for this to happen is going to be the right coronary artery, and it's also a very important detail. So it's the right coronary artery, and for the step 1 people, it is mostly going to involve this papillary muscle. I know the picture shows the other one, but this is just for illustration. We have 2 papillary muscles. We have one we call the posteromedial, which is the one that is most commonly going to be involved. And we have another one called the anterolateral. And this is unlikely to rupture. Why would the posteromedial rupture? Because the posteromedial has only one source of blood supply from the right coronary artery. So if you have an infarction involving the right coronary artery, then this will cause rupture of the posteromedial part of the muscle, papillary muscle, because it has only one blood supply. The anterolateral has actually 2 blood supplies from the right coronary and the left circumflex. So if the blood flow was cut off from one artery, you have another one that supplies it, so it is not injured. But in a posteromedial or in a right coronary artery infarction, the posteromedial is going to rupture because it's going to die and rupture. And then you're going, and sometimes they can also present that as a problem with the chordae tendineae, which are these small tendons that attach to the muscle and to the valve. And the thing that you're going to have is an acute mitral regurgitation. Mitral regurgitation means that the valve does not close. Okay, the valve does not close. The valve should close, the mitral valve, to prevent, when the ventricle is contracting, to prevent blood from flowing backward into the left atrium, and instead just flow forward through the aorta, the way it's supposed to be. If we have a mitral regurgitation, now blood, instead of flowing through the aorta, is going to be flowing back into the left atrium, and it might from the left atrium also flow back into the lungs, and that's why one of the most common presentations is going to be a pulmonary edema, in addition to a new systolic murmur, the murmur that is associated with the mitral regurgitation, which is going to be a hollow systolic murmur. So during systole, and you're going to hear it over the apex of the heart. And you might also have a cardiogenic shock. I'm planning to do one webinar in the future about the different types of shock, because super important concept. Cardiogenic shock, in a nutshell, means that the heart is failing. The heart cannot pump blood forward. And this is what is happening here, where the blood is not, instead of moving through the aorta, it is moving back to the left atrium. And this is one of the most important complications of MI. Another one, it would be interventricular septal rupture, where now instead of involvement of the muscle, we're going to have this septum rupture, and now we're going to have a shunt. Blood is going to be moving from the left ventricle to the right ventricle through this shunt. And this is also associated with it is also associated with a murmur. You're going to hear the murmur somewhere else. The murmur is mostly going to be over the left lower sternal border, and it is also going to be a hollow systolic murmur caused by this turbulent blood flow through the defect in the septum between the two ventricles, and you're going to have this left to right ventricular shunt. Now, what is the artery that is implicated? It's going to be the left anterior descending, the LAD. Why? Because the LAD is what supplies this part, the septum of the heart, with blood. So if we have cut blood flow there, the septum will die, it will be weak, and it might rupture. And the last important mechanical complication is going to be a free wall rupture. And in a free wall rupture, this means that the wall of the heart, so like this is the wall of the heart, all of it is going to die and rupture. And now the blood from the left ventricle is going to start leaving the chamber and accumulating around the heart in a sac around the heart that we call the pericardium. And this will cause a clinical syndrome that we call a cardiac tamponade. So cardiac tamponade, okay, I'm going to do it here. So cardiac tamponade, let's draw a drawing of the heart to discuss cardiac tamponade. This is the heart, and in the left ventricle, left atrium, right ventricle. In cardiac tamponade, you're going to have blood accumulate around the heart, and this is going to severely compress the heart. Okay, where the heart is not going to be able to pump blood forward because it is squeezed. You can think of it as like blood squeezing the heart, not allowing the heart to fully contract and eject blood forward. So you're going to have a triad of things that happen that we call them the Bix triad. Always look for the Bix triad to diagnose a tamponade, okay, which are going to be first the hypotension. Now, why do we have hypotension? Because now the left ventricle is compressed, cannot really pump fluid through the aorta. We should have the aorta here. And now, since you do not have enough blood flow through the aorta, this is going to show up as hypotension. The second thing is going to be a JVD, or a jugular venous distension, where the veins in the neck are going to be congested and dilated. And this is related to what we discussed with the right MI, same concept. Now, because the heart is compressed, the heart cannot fill with blood, okay, because the heart is so compressed. And now all of the blood that is coming through the superior vena cava back to the right atrium and the right ventricle, this blood is not going to be able to flow out from the right ventricle through the pulmonary artery. So instead, it's going to back up through the right ventricle to the right atrium, then the SVC, and this is going to show up as a jugular venous distension. And the last manifestation is going to be the muffled heart sounds. And I think this is pretty easy to explain because now you have so much blood surrounding the heart, compressing the heart muscle. So when you put your stethoscope over the heart to hear the heart sounds, they're gonna sound muffled because of all of this fluid and blood surrounding the heart and insulating the sounds coming from the heart. So you're not gonna be able to hear them. Sometimes they describe that as distant heart sounds, also kind of the same. So this is Bix triad, which is related to cardiac tamponade, which is a possible complication of MI that happens because the free wall or the wall of the ventricle is going to rupture, allowing blood to leave the chambers of the heart into the layer surrounding the heart. And this happens within 2 weeks, can happen in the first week, can happen in the second week. And the culprit vessel, similar like intraventricular septal rupture causing a VSD. This one is going to be a VSD. It is the LAD, and it's going to cause a tamponade picture. Now, the last complication that I want to discuss, I didn't know whether it would fit exactly in the mechanical complications, but it is sort of a mechanical complication, which is pericarditis, and it is super important because they can try to trick you, because we're going to have two different ways that we're going to have pericarditis. So first of all, I think we discussed pericarditis and the symptoms of pericarditis. Pericarditis means inflammation of the pericardium, inflammation of the layer surrounding the heart, or the sac surrounding the heart. And there is two different ways that pericarditis can happen. Okay, we have the peri-infarction pericarditis. The word peri means just around. So this will happen within like 3 to 4 days, maybe earlier, of an infarction. And the cause of this peri-infarction pericarditis is going to be the extension of inflammation. So what do I mean by that? Extension of inflammation, since now the heart muscle has died in an MI, this is going to cause an inflammatory response at the site where the tissue died. That's how our body does things. If you have any kind of necrosis or infarction, muscle, or any kind of tissue dying, you're going to have all of the immune cells, like the neutrophils and the macrophages, come in, and we're going to have a state of inflammation at that site. Now, this inflammation can extend to the sac surrounding the heart, cause irritation and inflammation there, and you're going to have peri-infarction pericarditis. Now, the second way that you're going to have pericarditis is what we call Dressler syndrome, or sometimes we call it post-cardiac injury syndrome. This is another name for it. And most importantly, this is going to happen after 2 weeks of an MI. So here the timing is super important. You have to be cautious. Look at the timing of the pericarditis that happened. Now, Dressler syndrome, we don't really fully understand why it happens, but the theory is that after the infarction of the heart happens and the muscle dies, there is going to be release of some proteins or antigens into the bloodstream, which is going to cause a sort of an autoimmune reaction where the body's immune system are going to be attacking the pericardium and causing inflammation there. So this is an immune phenomenon or something related to the immune system. And it is going to happen in at least 2 weeks after the MI. And now I want to go and maybe do 2 long-form questions where we can apply what we just learned, and then I can take your questions if you have any. So we're going to do the questions, long-form questions from our question bank, the MatchGuy, the Synapse question bank. It is the best question bank out there because you don't have to worry about doing thousands and thousands of questions that are maybe not high yield for your prep. This is only 1,400 questions that were carefully created to reflect all of the high yield concepts that are going to show up on your exam. And we studied all of the nbmes, all of the materials published by the USMLE to come up with the most important concepts. And then we tested each concept with a question. So if you study the questions and then review the answers and then study the whole thing, we can assure you that you're going to be passing. And we have a guarantee with this. If you study the question bank and you do not pass, you get your money back. So anyways, let's start going through the questions and discuss the manifestations that we see. So this is an older man, 64-year-old man, coming to the emergency department around 45 minutes after he started having some severe epigastric pain and nausea. Okay, so I still don't know what this could be. A stomach issue, right? Epigastric pain and nausea could be acute pancreatitis, could be a peptic ulcer, could be a million things. He describes the pain as a severe burning pressure in his upper abdomen. So like the pain character is burning in the abdomen. He has a lot of risk factor for coronary artery disease or acute coronary syndrome, which are the smoking, he's a smoker, type 2 diabetes, hypertensive, all are risk factors of heart disease. You should start thinking about heart disease. Now, he is on medications, lisinopril for the blood pressure, metformin for the diabetes, and atorvastatin for primary prevention of MIs. His temperature, okay, so blood pressure is slightly low. So he is hypotensive. So now I'm thinking about something a little bit more serious, Respirations are 16. He appears diaphoretic, so sweating could be a sign of AMI. And then they're giving us an ECG. Okay, so epigastric pain in older people, we also do an ECG for them because, as we said, this could be and this is one of the rare presentations of AMI. So you should not expect this in each question, but if you know this, you cannot be tricked. And then looking at the ECG, what do you guys think? I want some interaction in the chat. What kind of, is this an MI? What do you see? What kind of abnormalities do we see on this ECG? I can see ST elevation in lead 2, lead 3, lead AVF. And this is an inferior MI in a patient who did not present with a chest pain. They only presented with epigastric pain. But they have the risk factors, and we did an ECG, and the ECG proves a STEMI. So this is a STEMI. Now, what the question, and this is how also the questions on the exam are going to be, they do not gonna ask you like simple direct stuff. So they're gonna expect you, like the question are multi-layered. First, you're gonna have to make the diagnosis, and then they're gonna ask you some detail about the diagnosis. Like if they're gonna ask you about a drug, they're very rarely gonna ask you directly about what kind of drug are we gonna use. They're gonna ask you about maybe the mechanism of action of this drug. So let's see what they want from us. This patient is the greatest risk for developing which of the following complications? So they're asking about the complications over the next 24 hours. What do you guys think the answer is? So we have a lot of B, and we have some C, we have some E. So let's discuss these. So acute mitral regurgitation, left ventricular free wall rupture, ventricular septal rupture, bradycardia, pulmonary edema. So acute mitral regurgitation, we said that it could be, this is the artery that is implicated here is going to be the right coronary artery. We said that acute mitral regurgitation might happen in this, but it will be at least after 3 to 4 days. Okay, so it's going to happen within the first week. It's not going to happen over the first day of an MI. So I'm going to rule that out. And for the option B, bradycardia, I like this option because we know that it is associated with infarction of the SA node and the AV node. These patients are mostly going to present with bradycardia. They're not giving us the heart rate here, but if they did, I'm betting that it would be low. Left ventricular, because they have the hypotension. C, D, E, all of these, they happen with an anterolateral MI. We discussed that these are complications of LAD abnormalities or left circumflex. Does not have to do anything with the right coronary artery. So I'm thinking about B. If you guys agree, I'm going to submit the answer and let's see. Well, yes, it is correct. And bradycardia is a common presentation of an inferior MI. So let's see another one. So we're starting off with a 62-year-old man who's coming to the physician because they're having 2-day history of sharp chest pain. Now, sharp chest pain, we said that this could be things like maybe PE, maybe pericarditis, and they have a low-grade fever, okay, which can also be seen in PE or acute pericarditis. He says the pain is worse when he takes a deep breath or lies flat on his back. This is what we said is the description of a pleuritic chest pain, which again can be seen in both. So that's my differential now. 4 weeks ago, he was hospitalized for an acute ST segment elevation myocardial infarction. Now that is your clue. He has a very recent history of an MI. He suffered an MI 4 weeks ago, and now they're coming back with sharp chest pain. So now I'm thinking more about pericarditis. PE can still happen in the aftermath of an MI. So let's read more. So the MI involved the lad, and he was treated successfully with a stent, and then he started using his medications. All of these medications that we discussed are part of the management of MI. He is slightly feverish, blood pressure. The rest of the vitals are normal. On cardiac auscultation, we hear a high-pitched scratching sound. This is a very characteristic sound that we do not hear all the time, but if we hear it, it is very classic for acute pericarditis. We call this a pericardial rub. And it happens because when there's an inflammation in the pericardium, the two layers, so the pericardium is made up of two layers, parietal and visceral, they're going to be rubbing against each other because of the inflammation. And this is going to produce this sound. And next, so the troponin, which is the enzyme that we measure to see if we have an MI or not, is very low. So this rules out another MI. ESR and C-reactive protein, both of these are inflammatory markers. They should be elevated if we have any sort of inflammation in the body, and they are. So this is this confirms my hunch. This is definitely a pericarditis. Now, the next thing that we have to do is it the which one is it out of the two that we discussed? Is it a peri infarction or is it a Drisler? Last thing, so this question, if you're studying it like the way that I'm doing now, where you're going to go over all of the clues and remember and put them together. So here we have also the ECG manifestations that we see in the setting of pericarditis, the ST elevations diffusely and PR segment different. This is another way that they like to test. They're not going to ask you directly for diagnosis. They're going to ask you about what is the pathophysiology, what is the underlying mechanism. So you have to understand what's going on. And we agree that this is an acute pericarditis, but is it a peri infarction because of option B, direct inflammation from necrotic myocardium, or is it the other one, the antibody-mediated reaction against myocardial antigens, or sort of an immune reaction? Since here we look at the timing. The timing is the crucial factor here, and the timing here is 4 weeks. And we said peri infarction happens like right after an MI within a couple of days. So this is most likely going to be Drisler syndrome. Let's submit the answer, and it is. So this is, yes, this is Drisler syndrome. And here in the question bank, you can read more about the diagnosis. You can see why the other choices are incorrect, and then like a summary if you don't want to read all of that. And then we also have some associated flashcards that you can add with each question, that you can add to your collection of flashcards and review them. So now, if you guys have any questions for me, this is a very good time to ask them. How can we buy the question bank? So now I'm going to send you guys the links to our WhatsApp channel for the webinars, because we do a webinar like this every week. You're going to have all of the updates, and you can contact me personally or anyone from the team and ask about how to purchase the question bank, or if you want to see any of the other services. I'm going to be sending you now on the chat the link for our WhatsApp channel for the webinars, and you guys can join there and ask you. Yeah, so this is, I've sent you guys the WhatsApp channel link in the chat. Is the management explained same like Mona B? I'm not sure I understand Nathania's question. You're welcome, everyone. Good luck in your prep for the steps, and I'm sure that all of you are gonna crush it. If you feel like you need any kind of help, you can contact the MatchGuy team, and we're very happy to help you with whatever you need in your prep. Good luck, everyone. Bye-bye.